couple of years ago now, I was contacted by the World Health Organization after the World Health Assembly in 2013. A request came from that meeting asking for the development of a global evaluation toolkit that would evaluate health workforce education. The uniqueness of this toolkit is not just to evaluate what the current situation is in countries, but to actually be able to help them transform as they move forward. So a snapshot of now and a transformation, hopefully, for their future. And so I was asked to be a part of this working group, and was terribly intimidated at first because it's an incredible group of leaders and visionaries and people who have spent their careers changing global health and health policy, and just absolutely inspiring. And so I started working on this, and from that have evolved numerous other opportunities and conversations and partnerships and collaborations. One of them being the Transformative Education for Healthcare Professionals website through the World Health Organization. And that is, I've been asked to be a blogger on it, as well as to develop and bring forward case studies in both co-authorship as well as editor roles, to really show the global workforce that exists, workers that are similar to or analogous to the physician assistant in the U.S. The problem is, however, in global policy levels, is that the International Labor Organization does not have a category or a definition for us. So if you look in their definitions, you'll find, us, meaning the global PA workforce, spread out in technical areas, in paramedical areas, in you name it, we're spread from here to there. So rather than research being done and literature reviews, we actually have folks actively co-author or author themselves. We interview. It is really based from the country representative, and from that has grown an article and a research article, which will be coming out in the fall in the World Health and Population Journal, which was commissioned for us to really try to explore this workforce globally. The team that we developed for this research went forward to try to define the kind of PA analog workforce. And as we were doing this, and as I was talking to folks at the World Health Organization and other organizations that I've since become engaged with, phrases started popping up. Discussion was had as far as, well, we need to figure out a name that's going to be descriptive, that defines our category of health worker. And so through numerous very casual kind of, I want to call it organic kind of conversations, the accelerated medically trained clinician kind of came forth, and it seemed to be something that really resonated amongst folks at the policy levels, at funding levels, and basically it is a clear definition saying that we are trained under a medical model, we are regionally specific, we are clinicians, we are, because we're trained in an accelerated way, that's frequently, most often, regionally specific. We are cost effective because we have risen within our own countries and own regions, often in parallel to other nations. We are culturally and historically accepted within those regions. We also carry our own names within the regions that really define who we are, and I think to me it's vital that that remain. So the title of Accelerated Medically Trained Clinician is not something that clinicians will introduce themselves as when they meet a patient. It is in no way, shape, or form meant to be that. But what it is a category while I know the PA profession in the US is extraordinary and has really grown and over 100,000 strong, there are people that we don't really know about maybe who were further ahead than us in this kind of a model. The Feldshers in Russia in the 1600s. Mongolia has had something very similar for many, many, many years. That is a primary care, accelerated medically trained clinician type workforce that travels actually with the nomadic tribes there to provide primary care. Kenya has had, their clinicians since 1928, clinical officers. There's over 15,000 of them registered through the Clinical Officer Council. And I think that as you start to think of the global impact of this workforce, it's really exciting. They exist in Asia, Africa, Australia, Oceania, Europe, everywhere. The study actually concluded that we found them in over 48 nations. I think one of the vital parts of having the accelerated medically trained clinician actually officially recognized globally will be to increase accessibility of healthcare, because the hope is that this workforce will be able to expand through this recognition. We'll be able to continue the regionally specific work that they do. And the hope is potentially that regional models will be developed so that other countries that are interested, who have seen models at work, can reach out to places within their own regions rather than having kind of I don't know what to call it, maybe a colonial approach to, well, we have this and therefore everybody else should have this. I don't agree with that. I think that there are competencies that we are going to need to explore as a profession, meaning the accelerated medically trained profession, which includes, physician assistants, associate clinicians, medics, health assistants, medical. The list goes on for about as deep as 48 nations. As we build competencies in education, then those can go across the boards. I think that the competencies will be something that maybe are broader brushstrokes and maybe a little different than we think of traditional competencies. I see social determinants of health being a huge aspect in this. I see rural primary care or marginalized populations being a very important strategic aspect.
Have you always been interested in global healthcare, or is this more something new for you?
The travel bug, healthcare, global aspect, I think was inculcated in me very, very early without me knowing. So my father was a journalist for the Associated Press. We lived in Kenya, we lived in Egypt. Our home was always full of people from all over the world. I grew up knowing no different. As I went to PA school at the University of Utah, I was so drawn to the mission of primary care and underserved populations. And as I became faculty here in 2005, the opportunity arose to explore the potential of having physician assistant students do a rotation in Ghana, West Africa, where our university, School of Medicine, and other entities within health sciences had been involved for many years. So I was given the opportunity to go to Ghana by our director at the time, Don Peterson, and explore this. I was brand new to all of this. The very first visit, Dr. Hale, who's the global head of the School of Medicine, and our group went. It was actually a summit led by the Ministry of Health at the time, who was struggling with Ghana's horrible brain drain. 2 out of every 3 physicians were leaving the country after receiving training in Ghana. And at one time, there were more Ghanaian physicians in New York City than there were in the actual country of Ghana. Ghana has over 25 million people. So We met with the folks from the Ministry of Health, and at the same moment met Dr. Emmanuel Ajasi, who, to our great surprise, was the director of a physician assistant program in Ghana. Our partners in the US from the School of Medicine did not know that one existed. Dr. Hala and I were both just, oh my gosh, the planets have aligned. And the focus of the Ministry of Health at that time was, we need to scale up and bring forward this workforce of, at that time they were called medical assistants in Ghana. And they're a workforce that have existed since 1969. They are the absolute forefront of primary care in the country. They take care of over 75% of the primary care needs in the country. They're in the rural populations. They're in the underserved inner city populations. And they are the absolute backbone of healthcare. So, our timing of meeting, and a few short months later, we had a delegation that included the now provost from the university, who was at the time the dean of the medical school that the University of Utah had partnered with for so long, and Dr. Ajasi, the head of the, at that time, Kintampo Rural Health Training School, and folks from the Ministry of Health, the Deputy Minister of Health herself, came, and they spent a week here, and their interest was in seeing rural and underserved PAs in action. They were interested in sharing curricular ideas and seeing how they could change training, make their training more streamlined. And so started a beautiful collaboration, which has been ongoing now for 9 years. And just a quick story, that very first trip, they said, we want to see rural PAs. So, we rented a minivan, and I took them on a 1,200-mile road trip down to rural Utah, New Mexico, Arizona. They saw PAs in action on the Navajo reservation. They saw them in Arizona. It was the best thing to happen, because there we were looking at these phenomenally beautiful areas in our rural parts of the country. But for them, it was incredibly impactful, because they realized that we struggle with very similar issues. You look at the Navajo reservation, and you see their lack of electricity, their lack of access to health, their lack of water. And it's no different in Ghana. And so, those kind of moments really have built us into a partnership that is strong and enduring, of equal vision.
What would you say we could learn about healthcare from developing countries and what they do?
I'll take it from the student comments I've received over the years. I think that when students have gone to Ghana, we debrief every night, and that can range from very deep, very hard discussions about the infants that they saw die that day, to maternal mortality, to, oh my gosh, I'm really struggling with the bathroom facilities. I mean, the range is broad, but consistently what students reflect upon is their increased awareness of the critical nature of a history, the critical nature of the physical exam, and being able to rely on those things as building your differential, as determining your treatment plan. They all say, oh my gosh, I didn't realize how reliant I am on labs, on extra tests, to really help me define what I think is going on and to protect myself. And so I think that for me, one of the aspects that I hope someday we can get back to is really the art of medicine, and not relying on doing defensive medicine, because the zebras are zebras, but there's a lot more horses out of there. And part of healthcare costs and issues are because we're so worried about zebras. The other thing I think we could learn from, and really need to learn from is I think so many of our partners, and this doesn't just go for the accelerated medically trained clinician, this goes for healthcare in general, in their training, are really, really focused and are putting a strong emphasis on social determinants of health, community-based care, healthcare starting actually in the community with a small base team that then tiers into different layers where health professionals are used to their utmost capacity. You know, that PA who sits in their rural community clinic, their catchment area is usually 20,000 people. They are responsible for the disease tracking, kind of understanding surveillance, understanding the vaccination processes, keeping them up to date, having outreach programs that during the rainy season can reach these people in some of these more outreaches of this catchment area. Having a structure that really understands the population needs, the barriers, the access issues. And I hear these topics and they're being discussed with passion and excitement, but so often I'm not hearing the realization this has existed in so many places in the world out of dire necessity, and really we don't need to reinvent the wheel. Really we just need to learn from each other and be okay with that, and really maximize population care from the community level with teams, and obviously the accelerated medically trained clinician being a part of those teams.